Let's talk about personality disorders, first starting with definitions. So I'm going to read this. An enduring pattern of inner experience and behavior that deviates from the expectations of the individual's culture, pervasive, inflexible, starts in adulthood or or in adolescence or early adulthood. It's stable over time and leads to distress or impairment. And it's not explained by any other condition. There's cognitive problems with the perception of oneself and other people and events. There's problems in affect, in intensity, lability, and the appropriateness of an emotional response to an event. Problems in interpersonal functioning, and problems of impulsivity. So what's the difference between a healthy personality and a pathological personality? A healthy person learns from experience. They're flexible to adapt their behavior in new situations. They are able to achieve insight and perceive another person's point of view. They can experience pleasure without conflict. They can control their impulses, and they're able to work and love. Personality disorders, on the other hand, people are inflexible and rigid, and they have difficulty learning from new experiences. In fact, they may not at all. The patterns are deeply ingrained in their character. They have very limited insight into their problems. They have difficulty enjoying life as a result. They have struggles and conflicts in interpersonal relationships. They either are in distress themselves or those close to them are distressed, and they underachieve. Most of the disorders underachieve. There's an increased risk of other psychiatric disorders, including substance use disorders, increased risk of never being married or being divorced. There is lower SES as a consequence of the personality disorder. There's an increased risk of disability, and certain disorders have increased risk of criminality. So what are the clues that you're going to see as a physician? One is that there's this stereotype. They're almost like a cartoon character, like you can't believe a person actually acts like a cartoon. They're always blaming other people for their problems. Their symptoms are egosyntonic. The dystonic means you don't like your symptoms or you don't like your behavior. Egosyntonic is, well, of course, that's natural, that's the way it ought to be. A patient who quickly has a strong reaction to you, even after having met you for 15 minutes, we call this transference. Or when you have a very strong reaction to a patient, we call that countertransference. When there's a history of treatment resistance to psychopharmacotherapy or psychotherapy, and sometimes getting information from others who know the patient is helpful in making the diagnosis, as well as just seeing this person over time. Sometimes they can slip through the cracks, and only after years do you realize this person has a personality disorder. But these clues, very, very important to remember, as they are going to help you notice that they've got one, and that will help guide your management of the patients. Well, why do these people, if it's egosyntonic, why do these people seek treatment? Well, they've got comorbid psychiatric disorders like depression or anxiety, somatization, meaning they have all kinds of physical ailments, or they may present with substance use problems. Occasionally, they can be mandated to see a psychiatrist or a therapist by court or by an employer. They can be brought in by concerned relatives, which can be parents or significant others, or there can be conflict in a primary relationship, such as, a long-term intimate relationship. So the epidemiology in the DSM, they say there's a range between 5 to 15%, which seems kind of high, but if you consider milder versions of personality disorders, this makes sense. What we're going to talk about today is the more severe ones, but they all can be, they're all on a spectrum. 2/3 of those with a history of suicide attempts have personality disorders, and 80% of prison population, and that's mostly antisocial personality disorders. Now, you're going to hear, again, the people who were raised on DSM-4 call personality disorders Axis II disorders. This is because in previous editions of the DSM, we called Axis I all of the disorders that you've learned to date, and Axis II were considered characterologic problems. So depression is a state that can be changed. Antisocial personality disorder is a lifelong characteristic or a trait that cannot be so easily changed. Mental retardation is also something that can't be easily changed. It's a lifelong condition, and so that was placed in this Axis II bucket as well. But now we got rid of this because the idea is personality disorders are difficult to treat, but they can be treated, and there are biological, there's biological, psychological, and social situations that underlie personality disorders, just like other psychiatric disorders. And Axis II used to be quite of a stigmatizing phrase to say someone's got a personality disorder, and it would imply that they're not treatable. So this is why DSM-5 changed things. Personality disorders can see, and we'll talk about this, as subsyndromal manifestations of mood, impulse, control, anxiety, or psychotic disorders. And here you've got the survey showing 15% of US adults with obsessive compulsive personality disorder the highest, and dependent personality disorder has the lowest prevalence. There are 3 clusters, the odd or eccentric, which are kind of on the psychotic perspective spectrum. Cluster B, dramatic and erratic, so there's problems in emotional regulation and in impulsivity. And cluster C, which refers to anxious and fearful personality disorders. And we will go through all these one by one. So I just mentioned this, schizophrenia and psychotic disorders overlap with cluster A, mood disorders, impulse control disorders with cluster B, and anxiety disorders with cluster C. Really, the most common personality disorder given by psychiatrists is personality disorder non-elsewhere specified, where a person can have features of several personality disorders and don't meet the full criteria for a specific disorder. All right, so we're going to start with cluster A. These are the eccentric disorders that are most closely related to psychotic disorders. A person who is always suspicious of others, paranoid personality disorder. A person who has very eccentric ideas, circumstantial and tangential speech, we call schizotypal. A person who has very little interest in relationships or other interests in general is a schizoid personality. So let's first talk about paranoid personality disorder. So this is just distrust and suspiciousness of others. Everybody's intentions are considered malevolent. Males' prevalence equals to female prevalence. Now, this doesn't mean you think the FBI is following you. It means your peers have it in for you. They say nasty things about you. They want to get stuff from you. You know, the teachers are, have ill intent towards the individual, employers, etc. They're constantly misinterpreting neutral events as malevolent and with the aim to harm them. They suspect they're being exploited. They doubt the loyalty of friends or peers. They're reluctant to confide in anyone, and they read threatening meanings into benign events. They bear grudges for a lifetime. They perceive attacks that are not apparent to others, and they react with anger. And if they do have a spouse, they're always doubting the fidelity of their spouse or sexual partner. So I'm going to show you a few video clips of movies in which these characters are represented. And it goes along with the stereotypes of cartoon character, and that you see a person, you feel like, well, they're acting like just like so-and-so in a movie. So here we're going to look at the Caine Mutiny.
Medical log on Lieutenant Commander X-Ray. This log is being started because the possibility appears to exist that the commander of this ship may be mentally disturbed. March 5th, 1944. This evening, as usual, we were showing a Hopalong Cassidy movie on the forecastle.
Will you please stop this picture? Attention on deck. May I ask why I wasn't notified this movie was being shown?
Sir, last week you told me you couldn't look at another Western, so I just assumed you...
You assumed? This was calculated disrespect to your commanding officer. All right. There will be no more movies for 30 days.
May 28, 1944. Morale couldn't be lower. The crew was resentful. The officers just going through the motions of carrying out orders. This afternoon, the captain decided to hold a general drill for the instruction and safety of the crew.
This is the captain speaking. A great many men have ignored my orders about wearing battle gear. So there's only one way to drive the point home. Every man not wearing a helmet or life jacket will be docked 3 days' liberty. I see you! I want that knocked off. Stop putting on that gear. Mr. Keith.
Sir?
Put that man down there without a life jacket on report.
Which one, sir?
That one down there on #1 machine gun. You people think you're very clever. Well, you're not fooling me. Get that red-headed fellow over there. That one there.
Sir, it's impossible to tell which one is red-headed. They're all wearing their helmets.
Keith, you're an idiot. This is the captain speaking. Some misguided sailors on this ship still think they can pull a fast one on me. Well, they're very much mistaken. Since you've taken this course, the innocent will be punished with the guilty. There will be no liberty for any member of this crew for 3 months. I will not be made a fool of. Do you hear me?
July 30, 1944. Today we received a gift from the officers of the USS Pinckney. A gallon of frozen strawberries. I was checking the watch at 1 in the morning when I stopped to speak to Ensign Keith. How's it going?
Situation quiet. The captain's been put away for the night.
Lay off.
Steve, you know that I was with you and against Tom in the beginning. But I don't see how that cane can go on like this much longer. No ship can.
You haven't the experience to know one way or the other.
I'm not blind. I've watched the man.
All right, all right. Captain's in rocky shape, but he'll come out of it. He's got to.
Mr. Merrick, Mr. Keith, the captain wants a meeting of all officers right away.
Now, at 1 o'clock in the morning?
Yes, sir.
You know what it's about?
Yes, sir. Strawberries.
You sure this is a gallon can?
Yes, sir. It's a large can. Just took it from the pantry, sir.
I suppose you're wondering why I called this meeting. As you all know by now, we had an excellent dessert for dinner tonight. Ice cream and frozen strawberries. Well, about an hour ago, I sent Whitaker to the pantry to bring me another portion. He came back with the ice cream, all right. But he said, "Sir, there ain't no more strawberries." Now, gentlemen, I do not believe that the officers of this ship consumed a full gallon of strawberries at dinner tonight, and I intend to prove it. Mr. Merrick, how many portions of ice cream and strawberries did you have?
2, sir.
Whitaker, dole out a scoop of sand for each portion of strawberries.
Yes, sir.
Mr. Kiefer, how many for you?
3, Captain.
Keith?
2, sir.
Harding?
2, sir.
Painter?
2, sir.
Comedy?
2, sir.
Jorgensen?
2, sir.
Rabbit?
2, sir.
And the steward's mates had 3, right, Whitaker?
Yes, sir. One helping each, sir. Mr. Keith, he said it was okay.
Yes, I did, sir.
I had 4. 24 portions in all. Now, gentlemen, this tureen holds an amount of sand equal to the amount of strawberries we had for dinner tonight, right, Whitaker?
Yes, sir.
Mr. Merrick, take a look at this gallon can and tell me how much sand is left.
Maybe a quart or a little less.
Okay. Have any of you gentlemen an explanation for the quart of missing strawberries? There can be no doubt someone else finished them for us. As of now, gentlemen, you are all appointed a board of investigation to find out who's responsible for this theft. Mr. Merrick, you are the senior member.
You mean in the morning, sir?
Now, Mr. Merrick, according to my watch, does not mean in the morning. It means 0147. I expect a full report by 0800.
All right, pipe down. The faster we get this done, the faster we'll get some sleep. Send in the Miss Stewards one at a time for questioning.
Yes, sir.
If only the strawberries had been poisoned, all our problems would have been solved.
Strawberries, anyone?
You know, you're not going to be, most of you are not, well, 90% of you are not going to be psychiatrists. So why do you need to know about this? Well, this is how they're going to present in the medical setting. This doctor is going to treat me like a guinea pig. This doctor is being friendly because she wants to manipulate me. Doctors just want to make money out of their patients, so they're going to order all kinds of tests that I don't need. They think they're smarter than me just because they're doctors. Now, this is what they're going to think of you as you're trying to help them treat their cough, their diarrhea, whatever it is they're coming, their fractured femur, whatever it is. This is how they're coming in with these attitudes. All right, so how are you going to work with them? Empathize their experience. Do not challenge the patient's beliefs. So in other words, you're not going to say, well, I'm not ordering this test for the money. You say, well, I can see why you are reluctant to do the procedure if you feel that I'm just after the money. Respect their autonomy. Look, if you don't want the test, I can understand. I just need to explain to you the benefits and the risks. Respect their personal space. Don't get too close. Of course, you have to do your physical exam, but give him enough room. Explain clearly while you're examining, I'm now going to listen to your lungs. I'm now going to palpate your abdomen. Don't be overly friendly, and this is really important as you begin early in your career. You're probably going to be very friendly to patients, but especially with paranoid patients, if you detect they're paranoid, don't be overly friendly. They'll be more suspicious. Give them choices. You can get this test or you cannot get this test. If you get it, here's what we'll learn. If you don't get it, here's what might happen, and let them choose. Remember, they're going to be suspicious of medicines, and if they come to a psychiatrist and they're actually willing to get medications, we would do antipsychotics or antidepressants if they're depressed. I mean, I have a patient now that I've been treating in therapy who wants to walk out constantly, and I've been able to hold on to her because the entire family is insisting she be in therapy. She would benefit tremendously from medications, particularly antipsychotics, but there's no way I can convince her to take anything. So Glenn Gabbard was actually a psychiatry resident at Rush and has moved on to become one of the most prominent psychiatrists in the country. And he has here an example of how not to interact with a patient. So a patient says, I'm really angry with you because I've been sitting in the waiting room for half an hour. You told me to be here at 9:30 today. Therapist, no, that's not true. I said 10 a.m. You said 9:30. Therapist, I said 10. I wrote it down in my book. You're trying to trick me. You won't admit you're wrong, so you try to make me think that I'm the one who's wrong. If I were wrong, I would admit it. On the contrary, I think you are the one who won't admit to being wrong, and you attribute that to me. Patient says, I'm not going to take this harassment. I'll find another therapist. Here's how Gabbard recommends the alternative approach. I'm really angry with you because I've been sitting in the waiting room for half an hour. You told me to be here at 9:30 today. Let me see if I understand it correctly. Your understanding was that you were to see me today at 9:30 instead of 10? You said 9:30. Well, I can see why you'd be angry at me then. Having to wait for 30 minutes would make most people angry. You admit you told me to come at 9:30? You know, I don't remember saying that, but I'd like to hear more about your recall of that conversation so I can find out what I said to give you that impression. So, empathic, not arguing with the patient, being understanding their experience. So, how do you know they're not schizophrenic? Well, schizophrenia, they have 2 out of the 5 symptom clusters, and here it's just paranoia. How is it not a delusional disorder? Delusional disorder is far more severe. There's an encapsulated delusion that they're being followed, or that their aliens are visiting them. Something like that would be delusional disorder. Here, the person's taking neutral events in which it's certainly plausible to infer malice, so it's not entirely impossible, and it's more of an interpretation rather than a fixed delusion. Schizotypal personality disorder we'll learn about shortly. They do have paranoid ideation, but they also have magical thinking, perceptual disturbance, and odd speech.